Hey there, everybody. This is Andy Grider. I'm the host and producer of Unique This Week. It is a production of Uniqueness is Power. You can check out all the episodes at uniquenessispower.com or just find our YouTube link out there. Got dozens and dozens of amazing, compelling guests. One of them with us today is a guy named Paul Cella, who's a helpful disruptor in a very crowded marketplace. You know, we all like to look at things that are unique out there, or we like to look at people that are swimming in a very red ocean, which Paul definitely is, but he makes himself stand out from that crowd because of some unique things he does. We all know overall healthcare costs are on the rise for nearly every company across America, but that's especially true for hospitals and doctor practices because of the exact things that Paul focuses on bringing reduction to, and yet he enhances the benefits. These are called ancillary benefits, and they factor in a big way for finding and retaining top talent, as well as, if in effect, if they're poorly managed, the bad effect they can have on your bottom line. We'll get to all of that as we get into this interview, but I wanted to welcome Paul to the show. Paul, thank you for taking the time to be here today. It is an absolute pleasure, my friend.
Andy, thanks for having me, and I hope I add some value to the program.
Oh, I can't imagine you won't. I know talking to you before has been very revelatory. And I think our guests, especially folks that work in the hospital world, in the clinical world, on and on there, work with doctors, are going to find this very beneficial. So, how did you get into what is a very specific field of what I'll call cost reduction and benefit enhancement? And then give a little bit of an idea of how long you've been doing it.
Okay, so the name of my firm is called the KeyArx Group, which I'm the managing principal, and I can't believe I'm going to say this, but I've been doing this 30 years now, and I fell into it. I have a good friend and a dear client of a lot of years. One of my first clients was a bariatric surgeon in a hospital. And he asked me at the time, Paul, can you help me with that DI stuff, disability stuff? And I said, sure. I really didn't know a lot about it, but I quick became an expert because this was one of the smartest guys I ever knew. In his residency, surgical residency, invented a retractable syringe and wrote a novel because he was bored. So that's how smart this guy was. So he had a lot of people around him that respected him. But anyway, got him a disability policy. I saw how important it was to him protecting his most valuable asset, his ability to be a doctor. And then because of him, then I went into the hospitals and I started doing seminars to hospitals all around the metro area. And then, eventually just positioned myself as an expert in this area. So I wrote a lot of individual doctors, and then I started to get into the group side of it and wrote a lot of group policies. And it was interesting because I had a very, I really understood the subject matter, understood how the contracts worked. And I was writing a lot of disability policies where one day I got a call from a president of a large insurance carrier that insures over 150,000 doctors. And he was asking me how my close rate was so high. And I said, excuse me, what do you mean? He goes, Paul, the average close rate we prepare quotes is less than 5%. Yours was north of 70. And it's just knowing the contract and knowing it. So, that little bit of a progression, and I'll get into some more detail as we go, but hopefully that answers your initial question.
Yeah, I was going to say, so, and I want to be clear for our listeners because a lot of people hear the word you work in healthcare and they immediately think of healthcare plans.
Yeah.
So you have partners that focus on actual healthcare plans like medical benefits that aren't disability, long-term care, retirement-based things, but you're very niche driven on these few areas. Let's cover that briefly about the unique position you're in here.
Great question and great presentation to that. So we're not focusing on health insurance, period. Ancillary benefits are the group short-term disability, long-term disability, group life, and voluntary benefits. So we're laser focused, and the most focused we start is with the long-term disability. It's the biggest Achilles heel to the healthcare industry. So not the medical insurance, the ancillary benefits, and we focus on the physicians, C-suite, and again the other workers of the medical practices, large groups, like group purchasing organizations, GPOs, clinics, hospitals. So that's our world.
Right. And so when you talk about this, I've heard you talk about coming in and with the stroke of a pen in an afternoon, saving them significant money. Let's walk through how all this works. I know you're in a very unique position for what you're doing and how you're doing it. Let's talk about how this would work for a hospital or a clinic, and maybe an IPA, an ACO, any medical organization that you could work with. And again, with the high close rate speaks for itself. By the way, I did not know that. That's impressive. But let's
Well,
go back to to
okay,
where
so
you do.
let's talk about the unique position, Andy.
Yeah.
What the unique position is I am my firm, actually me. I'm a general agent of a number of the large carriers that provide the short term, long term, and life benefits to healthcare facilities or organizations. So, what is a general agent? To put that in perspective, there's probably over 900,000 insurance people and the licensed brokers in the United States. A general agent, one of the carriers I work with for hospitals, there's 18 general agents in the entire country. So this puts us in a unique position where a broker has to charge a lot of fees, commissions, and fees to get paid. We can work at a very compressed fee structure because we get supplemental compensation from the carrier itself, bypassing the individual. So when we say the phrase stroke of a pen, a lot of organizations, they're focused on the health insurance because it's typically the second largest expense next to salaries. On the ancillary benefits, it's kind of like not focused on, and it doesn't get its due. It's typically sold by the health insurance gentleman or lady who provides the health insurance that's good in that area, but they don't specialize in health in the ancillary areas, and they certainly don't specialize in the long-term disability. So what I can do to most organizations is come into the organization. Step one is no disruption. How can we work with the current carrier? HR doesn't want to hear disruption. The CFO wants to hear savings. So we can compress those fees that are being charged. We have an organization that, let's say I'm working on a hospital right now. It's in the neighborhood of $23 million in this area of spend. There's 2.8 million in fees and commissions. 2.8 million, that's a lot. I'm able to compress that down to 400,000. And no matter what the size of the organization, we can go through examples to get to that point. But phase one is to compress the fees. And phase two, or part of phase one, is looking at the contract and seeing if there's things within that contract that you could bring the cost down even further. And this is where I'm a design specialist. So I'll give you one example, Andy, is if you are a doctor and you're making $300,000 and you have a disability benefit, let's say 60% of salary to $15,000 a month of benefit. If you become disabled, well, 60%, you'll hit that number. However, I'll look at the group and I'll say, wait a second, let me look at the salaries of this group. And if you have doctors that are making 360 and over, you can reduce that 60% of salary maybe down to 50, and you'll still hit that 15,000. But by doing that, you might reduce the cost to that organization another 15 or 20% just by doing that. So the doctor's still getting the same benefit. So for me, there's a whole host of things that I can delve into to see how can we squeeze that and compress those fees.
Right. And Paul, the thing that blows my mind, and you kind of skimmed over it because it's commonplace to you. You see it all the time. But these huge amounts, $2.9 million in commissions coming down to $400,000 in fees. Not only that, but that's only the first level of savings that you can bring. So, but let's cover how is it possible that there are such huge amounts of benefits that are paid out in commissions?
It's it's the brokers have the ability to add in commissions, and it's a movable scale. So they can get a price for a long-term disability policy contract for the organization and say, I want to build in 5%, 10%, 15%, 20% commissions. And that's all going in that bottom line number to that organization. So it's something that's usually not discussed with the client and they're just not aware of it. So as a general agent, we have access to the carriers. We get paid supplemental compensation so that I can compress those commissions down. And some people just overdo it on the commissions, Andy. But it's not everybody. A lot of people, they just charge what I call not normal and customary for a side.
Well,
And it's all relative. That big example I gave you for the little firm, or the firm that's spending $200,000 in these areas or $20,000, it doesn't matter. the commissions are usually loaded in there pretty high.
So how do you reduce the effects of that blow to the bottom line? I mean, you're doing a lot of things to mitigate this. We talked about looking at the contract, finding places to bring things down. We talked about a couple of the other pieces that you can do. Um, the effects to the bottom line are largely because they've got a broker and a string of agents that they're paying, and that's probably why they're putting in the higher commission. You don't have any of that, right?
Right. So it's when I'll finish up on the two-phase process, Andy, because I think it rounds out the story, is that phase one is to try to compress those fees, try to find design modifications to make it better for the client. And that's phase one. Phase two is once we become the broker, then we can go to market and we have a unique auction process. And the auction process is now we go to all of our general agent contracts that focus in healthcare business organizations, practices, I should say. And then we can go go little to no fees because of that supplemental compensation. And we'll typically find another 20 to 40% save after phase one. And then that's that bottom line. Those savings are what the organization can choose to put to their bottom line, or they can redeploy a portion or all of it to get bigger benefits, sometimes 40. I've had groups 90% more benefit to the key people, the people that need it, the doctors. They buy more disability than any other industry, any other occupation in the United States. Physicians buy more disability. They want more. They just get premium fatigue, Andy. They don't want to spend any more money.
And those are very valid points. I mean, they're also too busy to pay attention most of the time. And there's another thing you do there that is really interesting with the planning and the report you can bring them. But let's talk about what the two most critical types of ancillary insurance benefits are for these doctors and medical staff. We've touched on it already. It's the disability and it's the long-term care or the retirement side of things, however you want to break that down. But let's talk about how that works and what you do there to present them something they can understand, digest, and work with.
Okay. So let's start with the long-term disability. In your working years, early years of a doctor, 40s and 50s, up until early 60 years old, I'd say long-term disability it's critical. The two most important insurances for a doctor are their medical malpractice, so they can be a physician, and their disability because it provides the income to do everything else in their life, savings, retirement, and whatever, what have you. So protecting that big income is important, and having the right contracts that will pay that doctor. Not all contracts are the same. So that's critical there. As a doctor matures in his 60s, theoretically he's amassed or she's amassed her wealth. And then the next phase would be you can start to dwindle or let go of the disability and then transition to something called long-term care, which will, if you want to get into, we can have a deeper dive on that. But that would be just a timing transition for the doctors. And most doctors don't buy their disability efficiently. And we can get into that.
Right. Well, let's go ahead and talk about why they don't buy efficiently. What is the key? Why does that happen?
Okay, so the women on this call are first going to be very mad at me, but then you're going to be happy. So the mad at me is females pay more than males for disability. And that's just a function of actuarial. They use the disability more than men do. And obviously pregnancy issues and that sort of thing. So there's just mental nervous issues. Females cause more than male doctors. On the individual side, this is a big, with individual disability, it's a big number. If a female 45 wants to have a $15,000 a month individual plan, female might be $9,000 a month, where a male may be $7,500 a year versus $9,500 a year. There's a big disparity there. So when I say overpay, is that most doctors that either belong to the hospital or have their own practice or are part of a practice, they're not utilizing and taking advantage of that group plan. I can get a group plan for a female male where it's lower than both get a discount. The females get a huge discount. They both pay the same rate. But when you coordinate these things together, you can have a female that's paying a tremendous amount of money with the individual disability, but bring that price point down 40, 50, 60% from what they were paying before. So there's just there's a coordination, Andy, that a dance that needs to be done, and looking at everything in totality. I provide, and I suggest if you don't have these with your advisor, but we look at all your coverages, and I provide these organizational insurance portfolio charts, which incorporates their disability policies they may have been getting since their fellowship and residency, and cobbling policies along the years. Doctors may have 5, 6, 7 policies, and they don't know what's in them. They usually don't know the bottom line number. So the first thing that I'll do is I'll start with organizing them. And then once we organize them, we can find out what's good or bad or expensive or not about those policies. That's my EKG. That's my X-ray, Andy, getting organized. And then I could look at it from my standpoint and say, okay, look at their group coverages and what could be worked. And maybe we can let some of the individual price that's high priced go and fill up more of the group side of it. So that's just it's an overall.
There's a lot to it. And I think
Yeah.
that's the other thing that's really important is that a lot of times they're not aware. I also heard you talk about things within disability where sometimes it's based on hours worked, and some people don't qualify, or a lot of people don't qualify because of that. And you've got a way to go in and get it to be by code or by specialty or other things like that. I think it's really important that people take you up on this analysis, on this DIEKG, as it were,
Mm-hmm.
and take the time to do it. But you also have talked about this a couple times here in the interview. And first of all, thank you for all the huge, massive knowledge you're dumping out for folks here. But the idea that you can help adjust contracts, I I know a lot of folks in the insurance world, and most agents, probably no agents, and most brokers really don't seem to have an idea that that can happen, that you can actually adjust a contract. Or if they do, they don't know how to do it. So, what is that like for you? I mean, why is that possible? Is that because of your status as a master agent, or what is that? Does that factor in?
It's not because of that. It's just knowing that it can be done. Andy, it's funny that you say it. I often take it for granted because I do this all the time. But changing a contract, I would make the analogy if you were buying a Mercedes Benz and went to the Mercedes Benz dealer and told them, I'm not happy with the contractual write up of this that your attorneys put together, and I want you to change these things and I'll buy the car. I bet Mercedes might say, why don't you go over to BMW and have a nice day? So they're
Yeah,
not going to change the contract. But in the insurance world, whether it's individual disability or individual life or long-term care, you kind of get what you get. There's no changing a contract. But in a group contract, I'll give 3 examples of a change. So let's say you were a nurse or a physician's assistant. Maybe your full-time job is maybe 25 or 30 hours. That's full-time for you. An
right.
ER doctor, I have the ER doctors that full-time is 20 hours. The typical group contract says 40 hours for full-time. So if your full time is 20 and the contract's saying 40 hours, well, guess what? At claim time, it reverts back to what the contract states. You're not working 40 hours, you're not full time. So you might get a reduced benefit in that case if you became disabled. So what I often will do is go to underwriting and say, hey, we're going to place the business here, but I need you to reduce the hours work from 40 to 20 or 25 for this class, the ERs or the PAs or the nurses or whatever it is, to adjust it accordingly. And then another one might be definition of earnings. Let's say the typical contract only includes W-2 income. That's how they write it. Well, wait a minute. There's W-2. Maybe doctors get bonus production for amount of cases or a 401k profit sharing contribution. Or maybe they have a surgery center over here and they have 2 surgery centers and they make income from 2 different locations or a hospital. So we'll modify the definition of earnings to include K1, W-2, bonus production, different sources of income to get there. And there's other items that you can do within a contract.
That's awesome. So you mentioned long-term care before. We're going to dive into that real quick. There's some new news, maybe not to people in the insurance industry, but to a lot of people around 19 different states in long-term care. And let's talk about how you're positioned to help out there.
Okay, so in my opinion, we're doing a lot of webinars for our doctors around the country. This would be a great separate podcast for you, Andy. But what's happening is this: Medicaid, like Social Security, is going bankrupt. That's the fact. So the states are nervous. We have, don't quote me, but it's about 58 million people over age 65. Only my facts I have from the seminars, less than 3% have addressed long-term care. So there's a huge gap. Over, I think it's 10,000 people a day are turning 65 until 2030. It's crazy, the numbers. So we have this aging population, the boomers, that's happening, and it's here. So long-term care is it's on the horizon. So what the states are doing, Washington State was the first to implement a payroll tax of 0.58% of on income for a $36,500 lifetime benefit pool, Andy, for care. Not going to be enough. That's a few months.
Yeah.
So, so that's not a good thing. And the plan itself there's activities of daily living, eating, bathing, transferring, continence. So these are items that if you can't perform these duties, that's what qualifies you to get the long-term care.
Right.
In the state plans, they're requiring 3 out of the 6 not to be able to do. Well, so this tax is coming down. Now the urgency is, if you can get a policy, and my webinars are about the types of policies you can do. I'll get into a little detail, but if you can get a plan ahead of time, you can potentially get grandfathered out of that tax. And then the individual type plans are 2 of 6 ADLs, not 3. So an easier bar to qualify for. The individual contracts, if you could take the same amount of money you were going to pay in tax in an open market, you could get more coverage, more pool of benefit for the same dollar. So what I suggest is the webinar is talking about, the upcoming tax. It's not going to happen until after the election, because it's an absolute time bomb on either side of the fence, but it's going to happen. And other than Washington, there's 19 other states that are on deck. California's next, and they're discussing a 1.2% tax. So the issue with long-term care is, I used to say, wait until your 60s to purchase it. Now it's affecting all of us. I don't care if you're in your 40s or 50s. If you can have something of substance that's meaningful for you and your spouse and build it into a retirement plan, is what we suggest. That's the way to tackle it. And I have a whole technique on the way you should buy long-term care and having the right plan.
Right. And so, I mean, along those lines, that is a whole other subject, and I'd love to actually have you back on to talk about it, because it's important. A lot of people need to know about it. And I would tell you, not only did you say that 3% have addressed that are over 65, and that's 58 million people, right? That's a lot of
Right.
folks. That's a good sixth of our country's population, or thereabouts.
Yeah.
Uh,
Yeah.
and so, it's not, it's something that people are not aware of, and they're going to get by it, especially the folks in their 40s, 50s, and 60s, who maybe 40s and 50s, they're not really even thinking about it right now. Um,
Yep.
so let's finish up here with the question: how does somebody get in touch with you for a free audit of their situation? And then also throw in how long that audit would usually take you to get back to them. And is there any payment you take for the audit?
No. Okay. Great question. So first, my email is paul@KeyArx.com, and KeyArx is KeyArx.com. So you send me an email and just give me some basic contact information, how you like to be contacted, email versus cell phone or whatever. An audit, Andy, is, I start with the doctor or the healthcare professional, where we get a list of the policies. So we would have a quick conversation, and then I'd say, Doc, send me over your disability policies, and if you want to send over your life policies, I'll organize everything for you and create the chart. And I'll put everything. My team will put everything in this organizational portfolio chart, and then you may not know the amounts, so we can get a letter of authorization, which is you signing a form to whatever company you have, XYZ company, and a letter of authorization allows us to obtain the records for you. Or oftentimes we call the company, get on the phone and say, Doc, when are you available? And he or she will say, call me at 10:30 on my cell, and we'll have the company on the phone, and then we go through each one of the policies and find out what riders you have, partial, cost of living, is it total only, the beginning dates, the benefit periods, and we go through all this, what you have at your disposal. You may be paying for things that have become obsolete. So we look at those, look at your group contracts, organize it all, and the time, it's not a lot of time on the doctor's part. It's an initial phone call, could take 5 minutes. Then getting the organization, send me a list, as long as it takes you to get your your policies together on an email and just listing them, the policy number, the company, and what you think the benefit is. And then with a letter of authorization or a phone call, we take it from there. So it might be a total investment of about 15 minutes on the doctor's part. It's not
Okay.
a
So
lot.
what if it's a group, Paul? What if it's a larger, like a hospital that says, hey, CFO says, I'm concerned about my bottom line. I see what you can do to help me out. I also have a turnover problem. I have a major burnout problem here. I want to take better care of my folks. How do I save money, not get crushed by the increases, and turn around and get something looked at here? How does that work for the company?
So, every hospital or organization has their current broker. If they want me to come in, I could show them immediately with a letter of authorization to obtain data, or I could look at what they're doing in their, with their census, their summary plan descriptions, their policies, PDFs of the policies. And then I can, with an authorization letter, I can contact the company and get the information I need, seeing what the commissions are, the fees and such. And then saying to that CEO, CFO, hey, if I were the broker, I could do this, I could reduce the cost this much. If they want me to go to market and keep what they have and just see what I can do in the open market, we would get a letter of exclusivity, which means CFO, CEO, I'm picking these 3, 4 companies that I am a general agent with, and I'm going to be the only person to market these and create my unique auction. And what I could do is then come back to them with the data, as long as I have the data in hand, and then I can come back to them with a real number. I had a hospital with 15,000 employees, 900 doctors. They had a 6 million spend in these areas. And with my auction process, I delivered them 1.9 million in savings guaranteed for 4 years. So it's just a function of, do they want me to just, go to open market, or I recommend the two-phase process that I mentioned earlier.
That's phenomenal. That is absolutely phenomenal, Paul. Again, so if somebody wants to get in touch with you, it's Paul at KeyArx, and I'll put that up on the screen for everybody so they have it. And the website is the same, so keyarx.com. One other thing we'll throw in when we post this on social media, Paul did an interview with Medical Economics, which is a really big deal, and did a fantastic job there. Answered some of the same questions he did here, but different. So I'm going to go ahead and just close things out here, Paul. Thank you for being here. Really appreciate you taking the time. Uh,
Andy, great. Thank you.
yeah, you're very welcome. Thank you. My name is Andy Grider. I'm the host and producer here at Unique This Week. We always are trying to bring in somebody doing something new, something different, something cool, something helpful, something that returns to your bottom line, something that you didn't know about before. And I think Paul pretty much checked almost all of those boxes, if not all of them, really well, and did it in a format that if you're a CFO of a hospital and you're not paying attention to this, I'd be surprised. If you run a practice and you're a practice manager and you want to really impress your doctors that you work with by bringing them something that they probably haven't thought about at all, beyond the fact that it's confusing and it's a pain in the tuchus. It's another thing, another place that you can do this. If you run an IPA and you want to bring a value add program, Paul's very educational about what he does with the webinars. Run a GPO, bring him in. Run a ACO, bring him in. Talk to the doctors that you have at your touch. Provide a huge value for them. Provide a huge value for yourself as the organization, as the practice, as the company, as the association, whatever it happens to be. Again, I can't stress enough that we all are facing increases across the spectrum in every type of benefit that we offer. And with this, to me, it's a no-brainer because you are avoiding increases, you are making decreases, and you're doing it in a very smart, effective way where you're getting a absolutely free audit of all of what you have going on. And if Paul can't help you, he's going to tell you that, but you need to find out. So take the time, reach out, see what you can do. Check out the other episodes. Share this with anybody you think might want to know more. But check out the other episodes on the channel as well. We've had a lot of amazing guests and more and more and more folks who work in healthcare. So if you're in healthcare, you're going to find a lot more things here that actually benefit you directly. Thank you very much for your time. Have a fantastic day, and we'll talk soon.